Well, I can see you now. I can see you now.
We'll just give everyone another minute and we'll make a start. Okay, welcome back, colleagues. Thank you for coming back so promptly. We are going to restart our meeting and I assume we're live again, Tom. I did note that the feed might have been off for a short while.
Yes, Chair, I can confirm we are live.
Great, thank you. Okay, well, we are moving on with our agenda now and moving on to item 11, which is our deep dive for today, which, as I said earlier, is linked to the patient story we heard about previously from Kath Gabain and is on stroke services. So, Mary, over to you, please.
Thank you, and thank you, Krishni. The purpose of this deep dive today is twofold, really. It's for the board to understand some of the key issues that are being raised about the stroke pathway within our ICS currently, and traditionally that has been the case, but also to acknowledge our approach to the future planning for stroke services within our ICS and what we intend to do going forwards. So I really welcome this opportunity for this deep dive. This has been a long journey on stroke, trying to improve stroke services, which some on the gallery have been alongside me doing for the last 7 years. So I welcome the opportunity to give you an overview of where we are. So just a bit of background, and Kath and I see that this story really aligns to what the issues of stroke are. So stroke is significant. It's one of the second leading causes of death and lost years of healthy life in the world. And for those of us that have been cared for stroke patients in the past, the aftermath of a stroke can be catastrophic to that individual and their family. And our health and social care services, the demand that is required to take care for these patients adequately is significant. So, and the national programme, which is a very defined programme for stroke, is in two phases really. It's the prevention of stroke, which I'll come on to later, how we prevent stroke within our across the country, but also when people are unfortunate enough to have a stroke, there's a very prescribed, nationally based standards of care that are constantly increasing those standards, and rightly so, to make sure that we have the least compromised position for that individual and their families. So it's our role in the ICS to make sure that we implement those national pathways as closely as we can and as fully as we can. So we have an ICS, a very well-established stroke programme board. It's a very lively, vibrant, challenging programme board, very good attendance, very good interest from all parties, including patient reps and our voluntary sector as well, and Health Watch play a big part in that as well. And it does cover the whole gambit of stroke. So it focuses on the prevention of stroke, primary and secondary prevention of stroke. And I think one of the interesting things out of the story to link, which I will take back to the programme board, is that link to diabetes and long-term conditions. We focus a lot on the hypertension, on the atrial fibrillation, the main known causes of stroke. We don't probably focus as much on in the other areas, so that's welcome to bring that back. But we do focus on the acute pathway when people do have a stroke, the post-acute rehabilitation phase required, and the life after stroke care. And there's national evidence that all of these parts of the pathway play an equally important part in the recovery of that individual. No part takes lesser importance. It all has to work together seamlessly to achieve the best outcomes. So we have spent the last 7 years in two ways, really. The first way is trying to improve the current quality of our services. So, and we have seen some improvements, which is really great to see. namely in the speed of access to our therapy services, which is measured as part of the stroke national pathway, and the care of our transient ischemic attack mini stroke care has really improved over the years. And that's been a mixture of quality improvement methodology and some targeted investment that we've put in over the years as well, and some really good work of the clinical teams to support those improvements. The hyperacute and the acute part of the stroke pathway, that's when people have had their stroke and are in hospital, has been identified as vulnerable for the past 7 years. And in fact, in at least 4 occasions, we've been in a very significantly compromised position, largely due to lack of consultant workforce for stroke. Now, this is a national issue. As ever, because of our geography and where we are, it's often difficult for us to recruit to. And we've been in such compromised positions that at least 2 occasions we've had to get support from consultants outside of our area and bring them into our area through our networks. And we've been greatly appreciative of that. And to be fair, it's worked really, really well. So that's been our key area of concern and risk that we've had in our system. So what else have we achieved? So we've gone on to the detail of the continual service improvement. So through the cardiovascular DES with primary care, we've done a lot of work on atrial fibrillation across the ICS, started in Worcestershire, being rolled out to Herefordshire. And just to say, we've been analysing the numbers of strokes that we have in our system closely over the past few years. And with the exception of last year, which saw a slight increase in the numbers of strokes, we're averaging 1,250 strokes a year across our ICS, which is about 24, obviously, a week. Getting benchmarking for this and where it is tricky. We're working with the region currently with public health to understand how we are on that, but we're not seeing any significant variation at the moment, either in the increase in strokes or the decrease in strokes from our work. But when we align that to our ageing population and the increasing size of our population, there's some interesting questions that we're starting to ask and look at the moment. But we know that we're doing the right thing by trying to treat atrial fibrillation, treat hypertension as the key causes of stroke to prevent that. So we are looking at our acute pathway with the staff that we've got, and we're looking at how we can use technology and other decision-making tools to ensure that patients get access to the right diagnostics very quickly. A key part of stroke. If you diagnose a stroke quickly, you can treat it quickly, you can reduce the impact of it quickly. And we're using rapid AI. Now, I went to see this myself, and I don't pretend to be able to explain that to you, but what it does is link up our 2 hospitals that our lead consultant for stroke and the ICS can see every scan of every patient almost immediately, to help in the decision making for thrombolysis, for giving that clot busting treatment very, very quickly. It looked very, very impressive, and we're one of the first in the region. We're not the first, we're one of the first in the region to put this in place. And with the belief it will speed up the access to that treatment, which we'll watch closely over the next couple of months to see if that improves the situation. We're also working with the national team and the regional team through some targeted funding on our rehabilitation pathway, and we're in the middle of an ICS-wide determination of how best we configure our community stroke services to give us more early supportive discharge for stroke in people's own homes, because that's best practice, and what the best model is for inpatient community rehab services going forward. One of the, despite the crisis of having to call people in from other areas to help us, one of the big benefits has been we successfully recruited a very experienced stroke consultant from another area in the region. He liked what he saw and he stayed with us. He's now the ICS clinical lead for stroke, and he has got extensive knowledge and is driving this agenda, which has been a welcome addition to our team and supporting improvement. But what has been really great, particularly over the last couple of years, we're now seeing our one system together, a real ICS approach, really working together, shaping and developing our services for the future and aligning what we're doing in a much more cohesive way than we had previously. So moving us on to some of the issues and the challenges. And preparing for the future stroke demand. So the standards we've been unable to meet, despite all of the quality improvement work, that we've had is that thrombolysis within 60 minutes of arrival at an ED. So we've done a lot of work on the pre-alert pathway that you heard in the story. So between the ambulance service and the trust, getting the alerts into the hospital, this patient's coming, we think it's a stroke patient, you need to be ready. So that's starting to improve. But despite that, you can see where we are at 62% against a target of 90%. And our overall thrombolysis rate is low. And the target next year is that 20% of all strokes will receive thrombolysis. So this rapid AI will help that I've described, but there's still a lot of work to do to gain that improvement. And our new clinical lead is retraining a lot of the consultants, the junior doctors, the advanced nurse practitioners on how we can improve that. And that's really good to see. Our biggest issue, though, is admission to a HAZU. A HAZU is a hyperacute stroke unit. That's once you've had the diagnosis of the stroke, whether you've had the clot treatment or not. We need you in a HAZU with a stroke consultant at the end of your bed in that first 24, 48 hours post-stroke, which is the most critical time for survival and your functional ability to be improved. We achieve 33% against the standard of 60% of that. And that is largely to do with flow in our system, but also the capacity that we have for the growing population going forward. And then patients spending 90% of their time on a stroke ward, an actual stroke ward, we're at 72% against the standard of 80. Now that has improved, but still some way to go and still some way to meet the demand going forward. And just to reiterate, so all the evidence shows non-compliance with these standards, particularly the thrombolysis and the admission to HAZU, potentially results in poorer outcomes for patients and long-term disability and increased mortality. So this is all about quality of care for those patients and reducing that burden. So we've been knowing that our population is increasing, knowing our elderly population is increasing. We've been modelling across the ICB with public health to map the increase in prevalence over the next 10 years, because the role of the programme board isn't just about the quality improvement now, it's looking to the future and future-proofing stroke services for our citizens. And it's anticipated that we will increase by 15% in the numbers of strokes that we're having. That's largely linked to our changing ageing demographic. So the facilities that we currently provide across our ICS, we've looked at them. They're not the best standard of facilities for stroke care, either in the acute part or the rehabilitation part. These patients need room. They need the ability to have lots of access to therapies, the space to do that. So that's an issue for us. But there isn't enough of the sort of HAZU, the acute stroke services beds in our system to support that future demand. So the case for change really continues to be compelling for the need to develop that sustainable solution going forward and reduce this from our fragile services risk register, because stroke shouldn't be on a fragile services position really. So we started this work some years ago. So the programme board has been overseeing the development of potential clinical service models for the future of stroke services, with the aim of delivering robust and sustainable 7-day-a-week services in line with those national standards that I've spoken about. And in 2019, we identified 4 potential service models, and we did a high levels option appraisal. Now, from that high level option appraisal that was scored by the whole system, clinically, non-clinically, and by the individual organisations, we identified the preferred clinical solution as one centralised hyperacute and acute stroke unit for Hereford and Worcestershire. And that was fully supported by the National Clinical Lead for Stroke, who came down several times to see us. And we were halfway through a clinical Senate process, but for several reasons, and COVID being one of them, that had to be paused. So we restarted the work post-COVID, and again, we were identified as a fragile service by NHS England for stroke. And we took some advice from the Consultation Institute, and we did a period of revalidation of the work that we'd previously undertaken. And once again, started that wider system engagement on what the future for stroke should look like. And to gain those views, and I've put the issues paper, as we affectionately call it, as an attachment, so you can see the outcome of all that engagement. So in light of that engagement work, earlier last year, the 4 potential service models were refreshed and reviewed again. We took into account the learning from COVID in stroke. We took into account the new technology that's available, rapid AI being one of them. And we again went through the process, and we took the 4 models and scored them against quality of services, accessibility, deliverability and sustainability, and patient experience, all with the aim of future-proofing our services for our population. And once again, this identified the preferred clinical service model as a centralised hyperacute and acute stroke service. Now, the scoring on this, there wasn't a massive difference between this and keeping the status quo as it is, but the clinicians, particularly in the room, and some of the managers believe that we can carry on like this, the model we've got at the moment. We can try to improve. We are still very close to a fragile situation where we have to put in business continuity. But for the future, they believe that the way forward is to have one fully functioning 7-day-a-week unit that will help to attract and retain clinicians and delivers the national standards for us. So the new model will also aim to manage the inevitable increase of stroke. Even if we do all the prevention in the world, we know with our ageing population there will be an increase in stroke. So currently we are going through the process of getting ready to go to a clinical senate, through the clinical senate process, probably April, May. We're just waiting to confirm the date. That will mean we'll ask the question about, is this the right model for our system for the future of stroke services? And in the background, we are preparing for a business case that would support this. Now that comes with risk, obviously financial risk, etc. But we will not, until we've agreed a business case, this will be subject to public consultation about sites, about the model, about the pathways. We won't go out to public consultation until we have agreed a business case going forward, and with all the surrounding the business case, the quality impact assessment, etc., will all be part of that. The big issues I think that that will come up against on this is and being open and transparent. Some clinicians would like to maintain where we are and carry on to improve. It would be a big change for some clinicians, and I think engaging them and bringing them on that journey is key. The public, when we did some public engagement on this in 2019, and when we explained to the public that they would be moving to their they would be moving hospital out of their area for particularly the HASU stay, when we described that unless you're very unfortunate, this only happens once in your life, but it's about the right care in the right place, and we would support with transport, etc., for vulnerable families. The public generally, they wanted the best outcomes for stroke. Really, that was their feedback. But we would have to go out to public consultation again. This covers Herefordshire, Worcestershire, and Powys. Powys, I didn't even know what Powys was when I first met these people, but I now know it intimately. They provide Wye Valley Trust and Jane provide their stroke services because of geography, because you have to get to the nearest hospital. And in the clinical pathways that we've just signed off, they would still go to their nearest hospital, which would be Wye Valley, for the initial treatment, but would then be transferred to wherever we deem to be this one unit going forward. So there's a lot of complexity here. There's a lot of feelings in this as well across the system. But what we're trying to do is prepare us for the future and make sure that we have a legacy where we have a very strong, robust stroke service for our population. So there's lots of detail in the appendix. You can see the amount of work that's going on. The teams have been great across the system, clinical and managerial, really working together now. We just need to continue on this journey and make sure we have a model for the future. Happy to take any questions.
Thank you very much, Mary. I think this was almost the first thing you talked to me about when I first met you at the start. So I knew this was a challenge from certainly my first involvement in the system. And I know it's quite clear. In many ways, it's the original fragile service, isn't it? That we've been doing a lot of work on fragile services, but this is one that has been in that kind of position for some time. But of course, COVID, has been a factor which we need to recognise. Okay, just start with some questions or comments then. Vicky, please.
Thank you very much, and thank you for that, Mary. We obviously covered some of this in QRD, and I guess the importance is the expertise 24/7, isn't it? And I was just wondering if yourself and perhaps Katie could just talk about the future workforce models for each of the scenarios, and just particularly the advanced clinical practitioner, how we can perhaps get people into training to support the model when it is agreed, so that we're not waiting for it to be agreed and then having a training plan.
Thanks. I'll start, and I'm sure Katie will want to come in if that's okay. So we have been working on the workforce model all the way through, and I'm really pleased to say we've got our first nurse consultant for stroke in Worcestershire. It took us a while to get there, but we got there in the end. And we are planning ACP roles, which will be part of this business case going forward. One of the early pieces of work we did, because there's a national shortage of stroke consultants, and when we analysed what our stroke consultants were doing, much of the activity could be done in a skill mix way. So that has been part of the work. We haven't completed all of that. What we have got now are the clinical pathways agreed, which is great for any new model, and we can design our workforce now along those clinical pathways, which we're using a STAR workshop approach. I'm sure Katie will want to come in to talk about.
Katie?
Thank you. I'd just really second what Mary said, actually, Vicky. We've got somebody working directly with the programme lead in the stroke programme now, looking at each of those options and then what the workforce could look like. And then we're doing an as is and a to be position and looking at what the gaps are, and then what we'd need to do in terms of training, creating new roles, upskilling. So that's using the different components of the STAR workforce model. So what we'll do as the work progresses is make sure we've got workforce models that sit alongside those, and then look at what we need to do to fill those gaps and where we need to go out and recruit. Alongside that, we've got some other work going on around medical recruitment and what else we can do to source consultants. And then we've got an ACP lead who's sitting down with teams and working out where we can put in more ACPs. But as Mary said, it's a real triumph now to have ACPs in that space, because that has removed the need for some expensive locums.
Fantastic. Thank you both.
Thank you. Aman, please.
Thank you, Krishna. Thank you, Mary. That was really, really helpful and really comprehensive. I've got a couple of questions. So, and apologies if this has been covered in other committees, but I think obviously the single site models seem sensible. But I just wanted to know, is this a model that's adopted in any other systems? And if so, is there any learning from that? And also you talked about rapid AI, and thank you for explaining what that does, because that was going to be one of my questions. And I think it sounds really exciting that we could be the first in the region to put this in place. Are there any other regions that already have this up and running? And if so, what has the impact been? Because I know in the engagement there was both positive and negative feedback about the use of technology. So is there something from those other regions we could learn that we could then communicate and instill trust in our community? So those were my two questions, please. Thank you.
Thank you. Very good questions, Aman. So when we first proposed this 7 years ago, a single site model, we were one of the first in the country to propose it. And there was a lot of concern about it nationally. Since that time, for exactly the same reasons that we are still proposing a single site model, many other places in the country have. Some are rural, some have copied that rural, the same issues as us, so they've now got one single site. Some are more like Wolverhampton, Walsall, Coventry and Warwickshire. They've now gone to one single site for their HAZU. What they have seen, what they're telling us, and what some of the indication of the indicator shows, is it's given them more resilience. It's given them the ability to provide that 24/7 care that was difficult before. And they're starting to attract more consultants who want to work, stroke consultants want to work on a HAZU and want to do that 24/7. So we don't foresee a problem with the clinical Senate process, because they have supported this in many other areas of the country. The rapid AI. So as just to be clarified, we're not the first. We're one of the first in the region to do this. But other areas of the country have adopted this, and the biggest issue is that the biggest benefit is that we can diagnose the clot earlier. We can look at the scan and see what the issue is, even if you're remote. So I saw in Worcester Acute, I saw Herefordshire's patients who'd had head scans and what their outcome was, and the advice given from that individual between the consultants was very rapid. that would have taken a lot longer. So I think it's working with the consultants to show the benefits, because there has been concern about this, definitely, from a clinical point of view, but it is becoming more prolific across the country. And I think COVID helped that. COVID did help that situation. So it is starting to be more recognised. So, you know, we envisage it will increase our thrombolysis rate, which is something we definitely need to do.
Thank you.
Thank you very much, David.
Thanks, Krishni, and thanks, Mary, as well. Looking at, and this is just for my understanding of what we're actually doing, Appendix 2 shows Model A and Model C, and it looks from the appendix as though we're progressing both Model A and Model C. Is that because, since we don't yet have approval for Model C, then we need to try to improve on the 2-site model, which is Model A, until we get approval to switch to the Model C? Is that what's reflected in that appendix?
It is, yeah. It's a bit what I said earlier, but it's an interesting question, David, and I'll just make it crystal clear. So Model A is improving where we are now, the quality improvement, the target investment. We will continue to do that, and we'll carry on that journey. Model C is that future one service in one acute service. Now, the timing of that, due to business case, public consultation, agreement everywhere, you know, we could be some way off that. So, you know, we're keeping both of the models working, so we're not just relying on the future. We're keeping that improvement now. So the programme board is very clear and very supportive of that now.
Thank you.
Thank you. And Nigel?
Yep. Thank you, Mary. As you probably remember, I sought assurance about a lot of this previously, but I am actually convinced that the single site model is sort of Model C is the way forward. My concern generally is that what I see on the ground is that there is considerable variability in ambulance response times, sort of across the board, and I just wonder whether that's been audited, because actually it's possible that might be the greater determining step if we've got poor ambulance response times, particularly in our large rural areas, and whether we've optimized, because a single delay by an ambulance, I mean, I see delays of numbers of hours sometimes, could have profound neurological impact on an individual and big impact on the system for rehab, etc. So I just wondered whether there was audit and assurance that we have about the ambulance service being able to optimize and limit any patient impact because of ambulance delays.
Very interesting question, Nigel. And I've been asked to a meeting about this very thing in the next couple of weeks. What this directly links to our urgent care challenges, some of our urgent care challenges in our system, and our ambulance delays outside hospital. And we regularly now have to help and support to release ambulances to go to patients such as stroke patients because of the speed of that. But in the business case going forward, there is going to be some consideration of the WMAS capacity, pre-alert capacity, their use of technology as well. There's places in the country that are able to use technology on the trucks to diagnose strokes earlier and to give treatment. So that's something we'll be exploring, particularly in our most rural areas, because you know it's difficult to get that time to the hospital at the best of times, isn't it? We need to get them there to scan within an hour, and that's sometimes difficult. So it is a challenge from an urgent care point of view at the moment, definitely. But in the business case, we will look for sustainability going forward. We also have to look at if we have a transfer to a single site from either hospital, we have to make sure we've got ambulances ready to do that, and that will be part of the business case as well.
Thank you, Nigel. I mean, actually, I'd written down category 2 ambulance handover delays. And so I was really glad Nigel mentioned it, because I do, that is a concern, isn't it, across the region? I don't think it's just a concern for us. And it's therefore interesting that we we're talking about the pathway very much from when someone's arrived at hospital, when in fact the pathway really should start, in my simple way of looking at it, from the moment that the ambulance is called. It is sort of, and that might, I'm talking about that very just in general principles. So I think thinking about what we do in relation to that in the way that Nigel's described, and Mary, you've obviously got some consideration around that, feels important, because it's all got to work, hasn't it, to make sure that people get to the hospital in a timely way. And if there's delays in that upfront moment, then actually presumably that has a knock-on effect, not just on the person's outcomes, but everything we're able to do and how we respond. So it just feels really important that we don't always just think about the start of a pathway as admission to hospital, from a kind of pure layperson's point of view, if that makes sense, Mary.
Yeah, no, totally agree.
Thank you. Tracy.
Thank you. You did, Mary, reference that obviously some other services may be impacted, and I just wanted to pick up on that a bit further, because if you co-locate all the stroke services or the majority of it into one site, then what other services may not be able to be provided at the other site? You know, there's high links with vascular, perioperative risks, all those sorts of things. So what are the areas that may be impacted as a result of this option?
Thank you. So we haven't predetermined where the site will be yet. We can't do that because we've got to go to public consultation. But through the process, we are looking at implications for the business case process of what this would mean for all of the other surrounding services. It looks minimal at the moment from what I'm being told, but that will be part of the process as soon as we've got through the clinical Senate sign off about the impact next. But what we've done is gone through extensive clinical pathways with everybody across the system. That's not come up as a major issue at all.
Thank you, Tracy, and again, Mary, for the response. A few more, Mary, to come, and we can draw it to a close. So Jane next, please.
Christian, thanks, Mary, for the update, which we talked about a number of times. So just a couple of points I wanted to make, and from a Herefordshire perspective rather than my wider role on the board. So I mean, your point's absolutely right, Nigel. I mean, that ambulance response time is critical, and you, Krishni, it's in a sense it's not really the admission to ICU from 4 hours of arrival. It's from when they call the ambulance is actually the critical issue. And it's why, as an organisation, the Wye Valley, we've absolutely prioritised that ambulance turnaround time for exactly this reason. I guess the other thing I want to say was just a bit of, because this is a picture of continuous improvement, Mary, and I think you've been saying, and so in a sense, what I wouldn't want the public to take away from this conversation is that they've currently got a poor service. Because actually there's a continuous audit that goes on around stroke standards, and actually Wye Valley has the best in the region and has done for some time on that, and our mortality rates are below what they would be expected to be. So there's already a pretty good service, but it's not as good as it could be. The next step for me, I think, is that you say the single medical lead is a really important step. The next step in terms of resilience is a single medical workforce, and that's something that Stephen and Glenn and I have been talking about how do we move to that single medical workforce to make it really resilient. And then of course when we get to the business case, we'll look at all of those issues of the deliverability and value for money and everything else that comes in that. So absolutely supportive of this twin approach that we're taking, which is to continue to improve what we currently have from what is already a pretty good base. And I just in a sense almost wanted to reassure the public around that point.
Thank you, Jane. Sorry. Mary, anything you wanted to comment on, or shall I just go to Nikki?
No, that's fine. That's absolutely
okay. Fine. Thank you. Nikki, please.
I was going to bring up the start of the pathway really being about preventing of strokes. So it was picking up on what Mary said. I think that the number of strokes in our area was pretty much flat over a number of years, and obviously with the demographic changes, aging population, comorbidities, etc., I think that's probably a success story. And we've done over the years a lot of work in primary care about identifying people at risk of stroke with irregular heartbeats or what's called atrial fibrillation and making sure they're on the right treatment. So I'm hopeful that's probably made a significant contribution to that. But I just wondered how we benchmark on a population basis versus the highest achieving areas, and are we preventing as many as we can? And if not, what are our action points to actually improve the prevention strategies and go a bit further to stop people getting sort of to that pathway in the first place?
Thanks, really good points, Nikki. We are trying to work with there's a regional network for stroke and our public health to look at some benchmarking. It's really difficult at the moment, but they're working on it. As soon as I get something, I can further brief on that. It does, from what I have seen though, it does look like we benchmark very well, but I can't, it's a bit like apples and pears at the moment for our population, which I think is a success story. Nikki, I do agree with you. I think it is a success story over the last years. I know some of the areas around us have seen an increase in stroke since COVID. Now we haven't. I had a little blip last year, only 100 patients extra in the year, but we're back down this year to where we were before. So we haven't seen that, and particularly in Hereford, we've seen, you know, that the numbers in Hereford are really quite low. So I think it is a success story, but we're going to continue to work on seeing what evidence we can actually get and show what else we need to do there. I do think that patients, the thing about diabetes, the other long-term conditions, I don't think we pay enough attention to highlighting the risks of that linked to the stroke agenda, which is something through primary care we'll have to have some discussions about, I believe, at some point.
Thank you very much, Nikki. It's a really important point that, you know, it really is. We need to extend our thinking to the prevention, and clearly that there's been a lot of focus on that. The diabetes point was picked up earlier, I think, and there is just, you know, so much, I guess, in terms of educating, making sure we're all educated about the things that are preventative in terms of stroke. So the prevention part of this is really important. And I think, Mary, you said you'd take the diabetes point in particular away and links to other long-term conditions. Right, Sarah, please.
Thanks. I could be brief because both Jane and Nikki picked up the points that I was really going to mention, which is really lovely when you're there to sort of champion health inequalities and preventative work, and it's already done for you. So yeah, the pathway starts really early, and I think we talked about this, actually just wanted to highlight at Strategic Commissioning Committee, we saw some of this work here and we did discuss some of this, also looking at that preventative element, hypertension, obesity, and then that links to health inequalities and our prevention and personalisation meeting, which we had as an ICB yesterday with really system-wide partners, and even there we were looking at things like childhood obesity and a strategy for that. So we're looking very long term at prevention by improving the health of children and all the way through. So where, Mary, you know, we've got a business case to produce, and this is a defined piece of work, and it's how we manage to bring everything else that we know is right in, so that we can get those longer term gains as well. And then with just a nod to our board assurance framework, that point 3 we'd got on there about health inequality reduction, we'd got listed population health management, hadn't we? And actually you can see through what you're describing, we are taking a population health management approach to this, and I wonder whether to help some of us and also to help the clinical senate, we can be sort of explicit a little bit about how we're doing that and how we're looking at different segments of our population, so different ethnicities and different groups, to really make sure that in what we're doing we don't widen health inequalities, but we target the services to those that need them for better outcomes. So I'm aware that work is going on, it's just making it perhaps a little bit more explicit. Thank you.
Thanks, Sarah. Mary, anything you want to add on that?
No, I think that's really helpful points. Thank you. I'll feed back to the programme board all of the views and issues. I think that they'll welcome the support, to be honest, from the board. And we'll keep people informed, particularly about the clinical study process and all the other work that we've talked about today as well.
Thank you, Mary. The one thing I did just wanted to pick up again, because we referenced it earlier in the context of the patient story, was psychological support piece. And it might be interesting, I don't know if Sarah Dugan might want to comment on this as well, just you know, psychological support for long-term conditions. So you know, stroke is one, you know, there's a particular perhaps support requirement in relation to stroke, potentially, I guess, because of some of the life-changing consequences that were illustrated or felt by our patient story. But more generally, I think the impact on mental well-being of long-term conditions I think is just something perhaps we're beginning to, or may already be well recognised, but I don't know whether the services are there to support people. So I don't know, Mary, if you can comment, and whether Sarah feels she can add anything in relation to talking therapies for long-term conditions, or whatever the level of support could be. Mary?
Thanks. I'll make a start. I'm sure Sarah and others want to come in. So it is an issue. I think, as I said earlier, you know, from the patient stories we've had, from the public feedback we've had at the stroke programme board, it's usually around that 6-month mark that people really psychologically need some support, and often it's the carers that need the support. You know, that's where they're really starting to struggle. We have life after stroke services in Worcestershire. We haven't got as much in Hereford as I believe we need, particularly from that psychological support. And as part of the business case going forward, I probably haven't made it clear, the business case won't just be about the acute bit, it'll be about the whole stroke pathway, which I'm just trying to break Mark into gently. So, you know, there is a need for investment in that psychological aftercare. We have invested some in Worcestershire. We did, I think it was a couple of years ago, Sarah, didn't we? We put a post in, it's one post, so it's pretty limited. But are we maximising across health, social care, the voluntary sector what's there? Probably not. We probably need to do more on that, to have to look at what we've currently got, which I'll take back to the programme board. But given the amount of strokes we're going to have in the future, we're going to need more investment in this area.
Thank you, Mary. So that you'll be building that into the business case is kind of what you're saying. Sarah, anything you wanted to add around psychological support?
Well, just to comment, it's good to see in the report that the work is still ongoing around the whole community rehabilitation and support offer, I guess. And I think I'd echo what Mary said. There's some fantastic work going on from the VCS and the Stroke Association. We've got a lot of peer support elements in place, which are also making a really big difference. Talking therapies has been more challenging in terms of access because we've had such significant demand post-pandemic. But I think our recovery plan is finally getting us to a point where those referrals can increase again. But I think it's that and beyond, isn't it? It's about the whole consideration of the impact of such a diagnosis on the individual and their families, and all of the support offer that's in place through the whole pathway. So I think there is a significant focus, but I completely support what Mary said, that there's always room for more. And I know you particularly mentioned the psychology element of it, Mary, as being something we might specifically look at, but I'm also keen that we really focus on the community support, and it will be highly relevant if we're looking at a one site model, won't it? Just to make sure that the care close for home, the rehabilitation and the follow through is as strong as it can possibly be. So it's really good to see that work's ongoing in the programme board. Thank you.
Thank you very much, Sarah, and thank you, Mary, for taking us through that so comprehensively. We've had a lot of opportunity for exploring this, and we're asked to just, at this stage, note the challenges to the stroke pathway within the ICS, and indeed some of the positive developments that have been ongoing, and you know, the plans afoot in relation to next steps. And there's obviously a timeline which is noted in the paper, which are the next stages, but although subject to change. And the key step seems to be the development of the business case and the clinical Senate meeting that Mary talked about. So thank you, Mary, for walking us through that, and to colleagues who've contributed to that deep dive. Okay, we'll conclude item 11 then, move on to our broader system quality and delivery report, which is item 12. So back to you, Mary, on that.
Thank you. Yes, so thank you. So the report obviously is giving you an overview of the work of the QRD committee. So it gives you the key risks around performance, quality and workforce from a resource point of view. So I just want to pick up on a couple of aspects. So we're obviously urgent care, we're in the middle of winter at the moment. We still have challenges in ambulance delays, our EAS performance, our 4-hour performance. We have implemented a lot of our winter plan now, but it's early days for some of it. It's being embedded. So our single point of access in Worcestershire is in. We went to see it, very impressed. It just needs to embed more and be used more. And in Herefordshire, that's just about to start the single point of access. We have more beds, acute beds in our system. We are doing more on virtual wards. We're planning more on virtual wards. We have seen, particularly in Worcestershire, I have to point out, we've seen a real improvement and an increase in WMAS referring straight to our urgent community response. It's quite significant. I saw it in practice myself. I was very impressed with what I saw. We just need to continue to work on that. There's always room for improvement, so we need to continue to work on that. But I have to say that since beginning of January, we have seen an improvement. Apart from the odd day, we've seen an improvement in the ambulance handover delays at Worcester Acute. It has been a much more stable beginning of January than I think I've seen for many, many years now. And I think the new approach and the new way of working is definitely starting to have some impact. We just need to now continue to work together and focus and embed it for the next few months, because we have now, we believe, all the elements in place. It's now making it work in practice that we need to see in the next few months. So and then our next piece of work, big piece of work, is around improving that frailty offer ongoingly to meet the demands going forwards. So that's urgent care. Elective and diagnostics. So our elective position, we still have some risk around our 78-week position, but we have a plan in place to eradicate by the end of March. Everything goes according to plan. We should achieve that, but there are some smaller risks that we need to mitigate, which we're ongoingly doing. What is pleasing to see behind this is I'm looking at the reduction in the 65 weeks and the 52 weeks. So whilst a couple of specialties are causing us problem at 78 weeks, we are seeing continued improvement in the 65 weeks and the 52-week programme behind it. So once we have concluded the issues in the specific areas, it does put us in a stronger position in elective care to take that next step and meet those next challenges. Obviously, industrial action has had quite a significant impact, although, again, we don't benchmark badly. We didn't cancel as much as other areas across the system, but it has had some impacts that we're trying to mitigate currently. The key area I'd just like to highlight is cancer services. Our patients waiting over 62 days remains a significant concern for us. We're seeing small drops in numbers, but nothing that's significant related to what we need to do on cancer. Urology and dermatology, as we mentioned previously, are our key areas of concern. And you can see in the report, I won't go into the detail, there's been quite a few reviews, action plans put in place. We are in a position where Wye Valley Trust will be taking the lead provider role for dermatology come April, although they're getting involved now, Jane, which is really helpful, supporting that. And we are working closely on urology with the regional, national teams and locally to improve urology services to meet the needs of those patients. So that is probably our key risk at the moment, I would suggest, is that cancer pathway, which we're working hard on. So that's all I wanted to highlight from the sort of performance side of things, and I know that Katie and Kath are happy to take any questions on the quality and the workforce aspects of the report, and also we've got the risks, any new risk highlighted at the back of the report. We're happy to take any questions on.
Thank you, Mary. Any comments or questions or anything that anyone wants to add in relation to that report? Vicky?
Thank you, Mary, for the report. I guess there's one area that you highlight in the report, which is the targeted work programme with care homes. I just wondered if you could expand on how far reaching that is and whether it covers both Worcestershire and Herefordshire.
Yes, I mean there is a programme across both places, both of our system. Sorry, across our whole system, but both places are taking a slightly different approach to their needs, which is right and proper. One thing we've done, which I think is really impressive at the moment, is we're because of trying to avoid unnecessary hospital admissions to attendances to the hospitals for the care home population. We have developed a deterioration pack. It sounds worse than it is. It's explaining to the staff there what to do when they feel their patient's deteriorating, what the first port of call is, how to treat them locally. That's been rolled out in Hereford and it's just about to be rolled out in Worcestershire. There's been really good feedback from the care homes on this. The care homes in Worcestershire are going to be directly linked into the single point of access. I think it's this week or next week that's starting, so they won't need that where they're having to phone either GP 111 and get advice. They can also get advice on that single point of access as well if they think we can avoid taking the patients to hospital. And there's also a full work of quality improvement, the general quality improvement in care homes, infection prevention, pressure sores, things like that goes on. We benchmark very well on care home attendances across the region, but again, there's always more to do. I think particularly on the end of life phase, very end of life phase, there's always more to do to improve that situation, but it's going well.
Thank you, Mary.
Thank you. Sarah, please.
Thanks. I think you picked it up when you were talking about it. It's just written in the paper. On page 3 at the top, we talk about progressing with the 65-week wait and talk about an ambition to achieve 0 by the 31st of March. Given what we've said about the 78-week waits in a few specialties, is that an aspirational ambition? And I suppose picking up on the BAF kind of wording, is that a target but not what we project? I'm just thinking sort of next time we have a board meeting, how likely are we to have achieved that?
That's a big question, Sarah. So we have targeted improvement plans in each of the pathways that we're concerned about, and if they are fully delivered, there is a reasonable assurance that we could hit that target. If more industrial action happens, I'd suggest that that's going to be difficult. Or if we lose any more workforce in those key pathways, both clinical and operational, because it takes the two working together and to make sure that we deliver the requirements, that does put it at risk. But from a pure modelling point of view, it is achievable. It also does rely though on productivity, on some greater productivity over the next few months, which we've had the GIRFT feedback as well. It came back with some excellent feedback, really on our progress, but also on some key aspects that we need to improve in our system. So the plan is there. If it delivers, we should hit the target. But looking at week on week, we are seeing the numbers improving, and that is giving us more assurance at the moment.
That's helpful. Thank you, Mary. So I think the answer was, in short, yes, but there are risks. I think
there's always risks. There's always risks.
Okay, David, please.
Thank you. Looking at workforce, I really welcome the stabilisation, the reduction in turnover, and the success in recruitment. I think that's really great news to see that. I do want to remind us all, and I know it won't be forgotten, that actually this almost just provides a little bit of a breathing space for us to continue to focus on engagement and retention, and that although we see the improvement in retention and recruitment, it doesn't mean that there's no more work to do. I think there's still a lot that we need to do when we can improve that situation. So I wanted to welcome it, but also to encourage us to continue on the engagement and retention front.
Yeah, thank you, David. I can see Katie nodding, so I'll let her come in if she wants to. Just Mary, something, and it might be other colleagues might want to come in on this, but it was really good to, I think a couple of places we commented on the increase in the use of urgent community response, which I think is really positive. I just wanted to double check there weren't any kind of clearly, if the usage of that is growing, just wanted to check whether there are any workforce risks around that in terms of capacity. There must be some limits to how much we can cope with and how much we're prepared for. So I can see Sarah's hand went up. So I don't know, Sarah, whether you want to come in, but it's a really positive story about the use of that service, because I think it's a really positive development, just what limitations there might be.
Yeah, I was just going to comment, and obviously I'm commenting for Hereford, so Jane, for Worcestershire, so Jane may want to add on Herefordshire, but we've seen since the investment in UCR, which is probably going back 18 months now, we've seen every month it's increased. In Worcestershire, we've now hit 1,400 referrals a month. But the resource that supports it, apart from the central team, is also embedded in the neighbourhood teams wrapped around the PCNs. So those teams, I think for the first time in the last month, we had a point where they were absolutely saturated and we had to sort of pause UCR referrals. So we do keep a close eye on it, but it is a very positive story about the number of referrals coming through. And there's quite a lot now where the ambulance service and others are seeking advice and signposting. So it doesn't mean the UCR service actually actively acts on every single one, but the metrics continue to improve in terms of referrals, which is really strong. So I do think we just need to keep an eye on capacity moving forward. But at the moment, the neighbourhood teams have done a great job. I also wondered if I could just mention, while I'm got the hand up, just about the integrated hub in Worcestershire as well. So we've just brought together, and I know Hereford are going to do the same shortly, but just brought together the UCR system together with the acute SPA, the capacity management team for community hospitals, continuing healthcare, and Pathway 1 for the local authority, and they're all co-located now here in King's Court 2, and that's really been another big game changer now in terms of making sure the patient referrals get to the right place really quickly. So some really good work going on in that space, and as I say, Jane may want to comment on Hereford. Thank you.
Thank you, Sarah. Shall I bring Jane in straight away on that, Jane, as we're following on from that?
You'd invited me in, Sarah. Yes, the numbers are broadly similar in terms of population, so we're over 500. That co-location piece is certainly in place, and also co-located with the virtual GP service. So that's really helpful, that link between the GPs and an urgent community response. So it is an area of success. The other thing that they're doing is they're what's called pulling off the stack. So they're able to see the ambulance call outs and where it's people they particularly know about or think that they can make a difference for. Actually, they can get a response out sometimes before the ambulance gets there, and we're having really quite a big impact on it's up to 7 or 8 ambulances a day we're diverting through that approach. So although our ambulances haven't grown particularly, some of it is because we are managing that demand in a different way. So a really positive story on that.
Great. Thank you, Jane. Russell, please.
Thank you, Krishna. I just wanted to return to Marie's sort of summary and apologise to members of the public who might be watching this because of the long waiting times you are suffering in all of the acutes. And as chair of those acutes, I'd like to apologise. I'd like to emphasise, and I'm sure Mark Dutton will touch on it, one of the key factors which is affecting our ability to drive as hard those waiting lists as we would like has been the industrial action throughout last year, and which is ongoing. It is extremely disruptive to our ability to keep our elective capacity at its maximum. It's also extremely debilitating to our staff who are working around the strikes, and I would like again to thank them. But the financial consequences, which Mark will touch on, means that resources that otherwise would be available for us to invest in prevention and driving those elective waiting lists down are having to be paid to very expensive locums and very expensive agency staff for us to be able to provide safe services. So I just want members of the public to hear my apologies, chair of the acutes, but also to recognise the consequences of the strike aren't just headlines in the various papers or news channels we might read. They have really practical consequences on waiting times and the costs of the NHS. Thank you.
Thank you, Russell. Helpful to have that perspective from you. Actually, just picking up, because I think the one other thing I just wanted to pick up, it was really good to see actually the frailty strategy development as well. We've had a bit of that covered in Simon's paper as well as this, Mary. More broadly about agency, so there is a risk that we've noted about increasing agency spend, and I think clearly the industrial action is a part of that. One thing, though, more broadly, is I think the analysis from the region shows that our agency proportion of agency spend in relation to our workforce is higher than other systems, and so I just wondered whether we're getting underneath that, and you know, of course, the rurality of our workforce, you know, the geography is going to affect our ability to attract people, but just something that I felt it was worth highlighting because it is important for us to understand what's driving that. And the other question is, with all of the sort of fragility around services and use of, you know, medical workforce, is there a risk that we're keeping people, you know, long-term agency use is contributing to some of our, particularly on the medical workforce, because the cost of that can be incredible. Is that contributing to some of that increased expenditure? So that might be a bit of Katie, might be a bit of Mark, but just be interested in your observations. Katie, please.
Thank you. I'll start with your second question first. Absolutely, there are some high cost locum spends in our system, and that is often because of the fragility of our services. And so some of the fragile services work is around how do you remove some of those high costs. Each trust has got a very detailed programme to understand their agency spend and to bring it down. We're very conscious of where we sit within the region, that we are quite a high cost spend area, and we're working through all of the reasons as to why. And I've sat personally with every CMO and CNO and heard, because they tend to lead the programmes, particularly for clinical staff, heard all of the things that they're working on to try and bring it down. So I absolutely know how seriously it's being taken across the system. We've got two big areas at the moment that we need to look at. So we've got quite a lot of off-price cap, and that is because of our rurality. And we've got some big expenditure in Worcester Acute, and that's the team there are looking at where that's planned activity that we're having to put staff in because people are off sick or, you know, not in work for any other reason, and where we are having to do things quickly and we don't have the workforce planned into our establishment to do it. So they're going through that at the moment. So we are really connected in with the region. We meet with them regularly, we meet with the teams regularly, and each trust has got a big programme of work to try and get under the skin of this. It's an issue we're taking incredibly seriously.
Thank you, Katie. That's really helpful. And yeah, I mean, I think clearly there's a lot of work ongoing. It's great to see some of our ambitions around our winter plan materialising into reality of things that we've implemented, and of course things like the frailty strategy. So clearly a huge amount of work ongoing. So if there are no further comments, just want to thank Mary, Kath and Katie for contributions to that report, and we're asked as a board to note the ongoing performance challenges, which I think we have done very clearly, particularly around urgent emergency care and cancer, although, you know, there are positive vibes around our elective care, but I think the risks Mary has outlined very clearly, and note the areas of quality highlighted and assurance in terms of patient safety. So thank you very much for that report, colleagues. We move on then, last but not least, to our item 13, which is our financial plan and delivery for 23-24. So over to you, Mark.
Thank you, Krishni. So good morning, everybody. In terms of the finance update, then it takes us to month 8. So it's as at November. of our 23-24 plan, and it covers both the trusts in terms of the overview of the system and also the ICB. Firstly, before I get into just a quick overview where we're at, for those that printed off the papers before yesterday, just a quick apology. Thank you to David Whiteman for pointing it out, but there was a formula error in one of our tables on page 2. We have corrected it. We've put the latest version onto the website, and we've corrected the source feed of that table. So where are we then at month 8? You'll see within the paper then we are still reporting a year-to-date deficit. So our year-to-date deficit is 36.7 million, and that is £16 million worse than the plan. So just as a reminder, we had a 19.2 million plan deficit that was phased across the financial year, and at the moment we are behind that plan. If you look then at month 8, our run rates have improved. So whilst we're still over and behind where we need to be, the run rate for the adverse variance has improved. Now, it's improved for a few factors. We've released some non-recurrent mitigating actions across the ICB, and we touched on one of them earlier. So we are seeing a underspend in the dental budget. It's not something we would like to see, because we would like to be spending our dental allocation. But again, we've brought that into the position now at month 8. And as Russell's just talked about, and the impact we're seeing around elective recovery fund, we are actually seeing more income coming in as a result of the elective recovery fund. Now, because of industrial action and some of the plans, we are having to outsource more of that elective work. So we've either got companies coming in to do work, which we refer to insourcing, or we outsource more work, so we give it to the independent sector or other agencies. So whilst we've got more elective recovery funding coming in, effectively it's a pound in and a pound out. So it's not giving a contribution as such to our overall financial position. We've also had some additional funding given to us from NHS England, recognising some of the financial challenges and pressures we've seen as a result of costs incurred in relation to industrial action, and we have released that into the month 8 position as well. So those are some of the main reasons why the run rate has improved. The areas, though, that are still driving why we are behind where we said we would be and plan to be are predominantly consistent. So excess inflation. We are seeing particularly large excess inflation pressures in prescribing, also in relation to our private financial initiatives, our PFI hospitals. Again, they are linked to the National Inflation Index, and also in continuing healthcare. Again, significantly higher than what we were advised to plan for and what we were funded for at the start of the year. Katie just touched on agency. Again, agency expenditure is a significant area of scrutiny, but again, financially is above where we said we were going to be. And again, that is driving some of our financial pressure. And again, as Russell's just touched on, as a result of industrial action and the fact that we're having to spend a lot of time planning as to how we're going to respond to that and keep services safe, we are behind where we said we would be in terms of our efficiency and saving plans. So again, there is a driver there, not in all areas, but predominantly within our acute trusts, we're behind where we said would be. So there's a combination of those 3 factors that is pretty much driving our variance of why we're not where we said we would be. You'll see within the report then there's the different analysis across the organisations, and you can see we are continuing to work on recovery actions and mitigations. Whilst the run rates have improved, we're continuously focusing on how, as we head towards 24-25 financial year, how we keep those run rates improving, keep them stable, and how we really understand now the impact on our underlying financial position as we move into the new financial year. We're doing a lot of in-depth work, though, particularly with Worcestershire Acute, understanding the run rate, what's moved, the impact of the recovery actions, and the work of the turnaround director in terms of how that will impact as we go into the new financial year. You'll see within the report we're still reporting though delivery of our financial plan. So that was the 19.2 million deficit. As we talked about at our last board, we were doing some work with NHS England in terms of where we thought we would be at the year end as a result of the significant financial challenges caused by the industrial action. We've not concluded all of that yet. We're broadly there, and for month 9, in line with the reporting, we will change our forecast outturn in line with where we expect to be, because you'll see from our run rates it would require a heroic effort and a significant reduction in service delivery, particularly as we're in the winter, in order to step those costs back down. The last bit we're still working with NHS England in terms of just trying to understand is the industrial action we've seen in December and January and the impact that will have had on revised forecasts. So we're just working through that at the moment, and once we've finalised that with NHS England, we will brief the board in terms of the impact that has on our finances this year, and then the impact that will have as we enter 24-25. Simon mentioned earlier, we haven't seen planning guidance yet or revised allocations for 24-25. We are still working though in the background on what we think 24-25 could look like, not just as a 1 year, but as part of a 3-year recovery plan, because let's be honest, our underlying deficit position is significant and is going to require a number of years work in terms of turning that around. And we've started some of those conversations at the ICS Finance Forum, and there's a number of work programs and things we're looking at there. We will refresh that as part of the 24-25 plans that we're doing across the system with partners, and I'm really pleased we've got aligned planning now in terms of the areas of focus and really trying to get underneath things like productivity, workforce, and how we deal with flow both in and out of hospital. And again, really looking to bring those plans alongside the joint forward plan and all the strategic areas and choices we said as a system we wanted to really see coming into play. I suppose I'll stop there, Chair. Take any questions, and again, we'll continue to feed back the work we're doing there and bring some of that back through the development sessions as we're getting very close now to 24-25 and the plans for the new year.
Thank you very much, Mark. Is there anything that anybody wants to comment on or question at this stage? Tracy, please.
Thank you. Hi, Mark. On page 9, there's a couple of big swings in the forecast. One prescribing, which you've touched on, inflation being a contributory factor, but I wondered if that was all of the swing that we're seeing. And then offsetting that to bring us back into balance is the additional reduction in cost and other programme services. And I wondered if that was delaying implementing some services or cutting back in some way, what impact on delivery there is as a result of that change.
Questions. Thank you, Tracy. So prescribing is predominantly linked to inflation. We planned at a 2.9% uplift. We're seeing prescribing inflation linked to pricing roughly around 11%. That's not unique to this system. Every area is reporting the same pressure and challenges. Just for context, our volume is broadly in line with where we expected it to be and where we planned, so it is definitely a pricing issue. In terms of the other programme services, within the month 8 position, that's where we included the elective recovery fund income, particularly linked to the independent sector, and also some of the community sector around things like dermatology and audiology. We will need to factor that through. It's a timing issue in terms of how we'd agreed what that would look like with NHS England and where we will feed that through. So that will come through in month 9. As part of the reset, though, between now and the end of the year, we have looked at some of our areas where we haven't spent some of the monies that we've been allocated in small areas around some of the service development funding that we've been given. We've not made any overt decisions to cut or restrict between now and the end of the year. We've just looked at where we've got some genuine slippage and underspend, and have brought that into the position as part of the where we think we will be at year end.
Thank you. Just a quick follow up on that. Is any of that ring fenced money, any of those specific allocations?
So none of the ring fenced areas or prescribed areas that we couldn't touch from NHS England have been restricted. So things like cancer services, mental health services, they will still continue as planned. This is more some of the discretionary areas where we've already got services and things in place. It just means in some of the areas we've not been able to potentially go as quick as we would like, and some of that effectively has been held back at this point in terms of not being fully utilised.
Thank you.
Thank you very much, Tracy. Russell, please.
Thank you, Mark. And I say to all of the finance directors in the system, you as ever have my utmost sympathy with the enormous complexity of NHS finances. I'd like to make a general point as chair of the biggest financial challenge in our system, which is Worcestershire Acute, and to assure members of the public and the board that there is a quite phenomenal amount of work going on to improve the underlying run rate. So forget the funny things you can do on a balance sheet to make an in-year position look right. Stephen and Caroline and Neil are leading a very considered piece of work to get the underlying run rates into a sustainably much better situation. As I said, the industrial action does make that more complicated, but that work will bear fruit. But it will take a number of months for it really to get to where it needs to be. And in my judgment, it will be the end of this calendar year before we are really starting to fire financially at the levels I would aspire for Worcestershire Acute. In the meanwhile, we're trying to optimise things as best we're able, but I am encouraged by the work that's going on under Stephen's leadership with Caroline and Neil's help to get the finances of Worcestershire Acute into the best possible position as quickly as possible.
Thank you, Russell. Very helpful context for Worcestershire Acute as well. So really good to note that position. Anything else to add, Mark, before we close?
Nothing from me, Chair, no.
Thank you very much, Mark, for the update. So we are really at this stage. I mean, clearly this is noting the month 8 position. There will be further updates going forward, and we've talked about the financial reset exercise. There's Mark has talked us through the deficit drivers, which are very clear and in common with many other systems. And I think we've had some good assurance around the controls that we're affecting to try and, particularly around agency and other areas that that we are affecting to try and make sure we do the best we can in difficult circumstances to control our financial expenditure and make sure we get the right balance between quality and finance. And of course, ultimately, though, we remain, committed in this difficult financial context to preserving patient safety, which I think is important always to say. So I just really want to thank Mark and colleagues for that report, and that brings us to the end of all our formal items, a little bit ahead of time, but I think there was a lot of commonality between the items that we were talking about, but it does feel like we've had a comprehensive discussion and aired some of those issues very, very openly, which is really important. So I thank everybody for their contributions. Thank colleagues and members of the public who may be observing us today. This will be available as a record of our meeting for people to watch back if they wish to. And our next meeting is on Wednesday, 20th of March, also on Microsoft Teams. So thank you everyone for joining us today, and enjoy the rest of your week. Thank you.